Good morning. This is Mary Ann Smith, and today I'd like to talk about age-friendly healthcare and systems in relationship to 1M mobility. Our goals for today are to provide a brief overview of mobility in the context of the 4Ms, and then we'll talk about some screening tools and interventions to advance good mobility among older adults. I'd like to acknowledge that this program is one in a series of 8 about the 4Ms and is co-sponsored by the Somé Center for Gerontological Excellence and the Geriatric Workforce Enhancement Program at the University of Iowa. The content is based on age-friendly initiative of the John A. Hartford Foundation and the Institute for Healthcare Improvement. We really hope that everyone will explore additional options about joining this important social movement at the website that is noted here at the bottom of the slide. So let's go back and talk about the 4Ms in healthcare and in healthcare systems. There are lots of good reasons to use the 4M framework: what matters, medication, mentation, and mobility. It's a best practice that applies across all healthcare settings, and it focuses on the person, not the diseases that the person has. And it really addresses quality of life and living, not just adding more treatments or transferring people to acute care settings for more treatment and care. So when we think about mobility as one of the M's, let's put it in the context. Most health and life goals, are activities that require mobility. Mobility is really central to doing what matters most, doing what's important, getting where you want to go, doing what you value, what is meaningful, and that all contributes to quality of life and quality of living. Mobility also interacts with the other M's. Impaired mobility increased risk of falls is associated with medication, as listed here: benzodiazepines, other psychoactive medications, anticholinergics, anticonvulsants, and antihypertensives, which we'll talk about more in the program about medication. And impaired mobility can occur in the context of mentation, particularly confusional states like delirium and dementia. And as before, when we think about the 4Ms, we can't think of them as being siloed because they all interact with one another. So let's think some more about this issue of fall risk, because that's huge when we talk about mobility. And as you notice on this slide, most fall risks are highly preventable. Lower body weakness, vitamin D deficiency, problems with walking and balance, medication side effects, vision, foot pain, footwear choices, home hazards. These are things that we can change, meaning that we can promote safe mobility and avoid falls. So let's keep that in mind as we think about acting on mobility in just a few minutes. Now, it's also important to say we don't want to just tie mobility to fall risk. There's so much more value beyond reducing the risk of falling and having additional health-related problems because of that. Physical activity is a key prevention strategy in heart health, lung function, managing pain, increasing function, and enhancing our mood, stress, anxiety, and depression, and definitely in promoting better sleep quality and appetite. So there are lots of reasons that we would like to see older adults maintain their mobility. So in the 4M's context, The definition of mobility is ensuring that older adults move safely every day in order to maintain function and do what matters. Try to keep that definition in mind because it's really quite simple, but it's also quite important. Moving safely every day to maintain function and do what matters. So, like other age-friendly topics, we think about key actions in terms of assessment and acting on findings. So in mobility, we want to identify and treat those contributing factors, the things that increase the risk of falling or reduce the opportunity for people to move safely. We also want to screen for mobility limitations, meaning that how is the person currently doing in terms of their walking, turning, standing, and how can we help them do better? So that's where acting on our findings comes into play. We want to support movement every day, and we want to support the person's mobility goal in order to do what matters. And that may include referring the person to physical therapy or possibly occupational therapy. So when we think about assessment, there are a few tips that I think are important for us to keep in mind. One is that we should probably be thinking about older adults who are at risk for functional decline. And then we want to think about what is their baseline function on a good day at home and as they enter healthcare systems. Ask, what is needed to help this person maintain their function? What is needed to prevent or treat complications of frailty or immobility? And then we want to ask who and what needs to be involved to maintain mobility and function. Remember, it's so important. This isn't something that any one of us is going to be able to do alone. Team approaches are absolutely essential to high quality 4M care. This goes across all of the M's: medication, mentation, mobility, and certainly all members contributing to gathering information and supporting mobility goals. So please don't think about it as I have to do this alone. Think about it as very much a team approach. So back to this idea of screening mobility. There are lots of really good tools. Get Up and Go, Timed Get Up and Go. We're going to talk about each one of these in just a minute. And before we do that, the thing I'd like to make really clear is that while each one of us may not be prepared to do the mobility screening, it's important for us to understand what goes into screening. What are the things that are included? What are we watching for? Because as a nurse, for example, I may not do a timed get up and go test, a TUG. But as a nurse, I am definitely going to be watching how this older adult walks, how they get out of bed, how they transfer to the toilet. I'm going to be thinking about what their strengths are, what their frailties are. And that is very important information that becomes part of the discussion in team-based care. So now let's talk about some of these tools. The Get Up and Go test is really pretty straightforward. The older adult rises from a sitting position, walks 10 feet, turns around, walks back to the chair, and sits back down. So there's a lot that goes into that in terms of standing without using your arms, walking 10 feet, turning 180 degrees, walking back, and again, sitting. So that's one way to think about it. And we can watch for all kinds of additional factors when the person is walking, which we'll talk about here in just a second. So the timed up and go, or the TUG, is really the up and go, only we add the dimension of timing it. This is a really, I think, interesting and important framework on the slide, because this slide that actually comes from the CDC, and you can access there at the bottom of the screen this particular scale. Notice that there are these additional observations: slow, tentative pace, loss of balance, short strides, little or no arm swing, steadying themselves on the wall, shuffling gait. Those are the observations that we as providers may make without necessarily administering a timed up and go test. Really important information, document in the chart, talk about with the team, and then someone else maybe can do the official screening. The Performance-Oriented Mobility Assessment, or POMA, is another really good source of the kinds of things that we should be watching for, monitoring, thinking about when we're watching older adults walk, move, transfer. What goes into their mobility? Where maybe are they having some challenges? And I know this is itty bitty, teeny tiny print. So please go to the website that's listed at the bottom of the scale, print it out, read it, and think about it. Because on the one side of the scale, we're thinking about the person's balance, how they rise from the chair, all of those factors about standing, can they stand while they close their eyes? Those kinds of things that are important to mobility and safe mobility. And on the other hand, we're thinking about how they are following in terms of gait. So one is balance and the other is gait. The last screening tool that we'll talk about is the Johns Hopkins Highest Level of Mobility Scale. And again, you can Google this, just JHLM scale, and find it pretty easily. And again, it's the idea of walking, standing, transferring from the chair, and what happens sitting at the edge of the bed, being able to turn themselves in bed, and certainly lying flat. So there are a lot of things that go into mobility, and different scales look at different aspects. The most important message is it's less about the tool and more about how you would like to use it. So we each need to think about the setting that we're working in, our care environment, and select the tool that best fits what we do. Train our staff to use it, or contract with someone who's going to apply it for us, use it consistently, document our findings, and then also think about all the contributing factors that may be going into unsteady gait or balance issues. So that brings us from assessing back to acting on our findings. So once that we understand better what the older person's mobility issues are, if they have issues, then we want to think about how can we keep them safe. So first of all, we want to think about environmental issues, and then we want to identify and set daily mobility goals that supports doing what matters most to the individual. We definitely want to avoid those high-risk medications that have side effects that contribute to risk of falling. And we want to see older adults doing some kind of regular exercise, no matter what level of exercise that might be. So movement every day to maintain function and do what matters most. So back to that list, think about all the stuff that can interfere with mobility, the person's pain level, problems with strength, balance, gait impairment, deconditioning due to immobility. And this is a huge issue for older adults who are hospitalized and on bed rest, and decondition, meaning they lose muscle mass really rapidly and therefore are at risk for having falls. We also know that there are a lot of treatment-related tethers in acute care and post-acute care settings. Catheters, IV lines, telemetry, all kinds of things that reduce movement. So in addition to thinking about the factors that interfere with mobility, we want to make referrals to physical therapy to keep people moving. We also want to help that older adult set a daily mobility goal to do what matters. We want to build on their strengths and abilities. What are they able to do, as opposed to what they can't do? And we need to remember that variation in older people is a norm. It's not the exception. We need to start where the person is based on what's going on now and revise mobility goals as needed. So as people transition from one care setting to another, from home to the hospital, from hospital to skilled care, from skilled care back home, and their health status changes, their goals for mobility are also likely going to change. So what we do in the hospital is going to probably be a lot different than what we do at home or another care setting. So one of the best examples, this is so critically important because the risk of deconditioning is so high in hospital settings where people are often on bed rest, and maybe on bed rest for good reasons in lots of situations, but in other situations, possibly there are opportunities that are being missed. So I think it's important to think about ACER-CIDES, which is acute care for elderly, and in an ACE unit. So we think about frail elderly all being cared for in the same unit of the hospital. But even in that setting, some hospitals are starting exercise programs for older adults who are hospitalized to assure that they don't decondition, that they maintain function as best they can, so that they are better prepared to go home and be successful. So our hospital mobility checklist, I'd like to give special credit to Dr. Paul Mulhausen, who shared this information in another program about mobility. And he includes on his hospital mobility checklist that we should be screening mobility once a day. Every day we should be thinking about their up and go or their timed up and go opportunity. We should be walking, ambulating at least 3 times a day, if at all possible. We definitely want the person to get the person out of bed, or possibly leave the room for meals, and definitely make referrals to physical therapy for balance, gait, strength, gait training, and additional exercise that the person can be doing a little bit later. We want to be restraint-free, meaning don't tie people down, and we want to remove catheters and other tethers as soon as that opportunity exists. And definitely no high-risk medications. So thinking about outside of the hospital environment, another opportunity might exist to engage the older person in conversation about a mobility plan, a personal mobility plan. And the CDC offers this opportunity through My Mobility Plan. Myself, my home, my neighborhood. I think this slide, this is a screenshot of myself, and it emphasizes, I think, the really important things that each older adult can do related to self-care and staying independent. Getting a physical checkup every year, reviewing medications with your provider, making sure you get a medical eye exam, making sure your vision is good so you can see what's going on around you, and certainly following an exercise program to increase your strength and also your balance. It's a really interesting fact. A lot of people emphasize walking, and walking is really good for us in a lot of different ways. But strength and balance are the things that more often will help reduce falls. So it's important to think about when we set these mobility goals and exercise opportunities to focus on the things that are going to be the most useful to the target goal. So a chair stand, for example, will increase strength, and Tai Chi is really great for improving balance. There's another great set of opportunities and information that are available online as illustrated here on this slide. And the thing that I think is so very important for us to try to remember is that regular exercise doesn't really need to be strenuous. It doesn't really need to be time-consuming. I think it's hard sometimes to get motivated to get a program started because we're saying to ourselves, oh, gee, I just don't have time. Oh, gee, I'm not sure how we can fit that in. Or, oh, gee, do we really have the staff to be able to help that person? Yada, yada, yada. You know? So stop and think about what the opportunities are. And I think this website is so really helpful because it talks about exercising with chronic conditions and all the opportunities that occur in that context. And as you can see on the slide, there are a lot of other great pieces of information: how to get started, what are the real benefits, what are some main types, what are some safety tips. So in the context of how we help an older adult act on their mobility, how do they set a mobility goal, having some additional information about what the opportunities are can be really helpful. So again, there's a home mobility checklist. Again, thank you, Dr. Mulhausen, for how we think about safety assessment, putting things in easy reach, reducing trip hazards. These are our scatter rugs and our drop cords that make it really easy for us to trip and fall. Having a lot of good bright light so that things are easy to see. And again, lamps within easy reach. And there's so much more. I would encourage everyone to explore the on-site, or rather online opportunities about home safety checklists. Physical therapy and occupational therapy consultations are also a great idea. Using adaptive equipment, having a physical activity program, and again, vision referral and assessment, and no high-risk medication. The last thing that I would like to visit about is this idea of fall risk management or fall risk aversion. So there are lots of prevention programs in the marketplace today. Many of them are being offered in person, and many more in today's environment are being offered online. So here is a list of some that you might want to explore. STEADY, which is featured in the photograph, A Matter of Balance, Stepping On. And I would also like to emphasize Tai Chi, which I believe our Geriatric Education Center is offering as a virtual program, and would really encourage everyone to try out. So in summary, mobility is an incredibly important topic when in the context of life and living and doing what matters most. As healthcare providers and family members and older adults ourselves, we can identify and treat the things that impair mobility. Think about the slide about risk factors for falls. Think about home safety. Think about what goes on in the hospital. So Putting that all in context, how can we prevent issues that will impair mobility? We can also support individualized mobility goals across care settings to promote health, well-being, function, and enjoyment in living. Thank you so much.